I always thought that there was a space outside of the conference room where conversations happen, and those conversations are super valuable.
When I joined BackTable, at that time I was like a private practice guy who was trying to like go to conferences and talk, and it was just hard. I wanted to have a voice too.
There were some bumps along the way that led me to have to essentially reinvent myself at what I thought was a senior point in my career.
I remember going back to my first case, like I had no idea. I was figuring it out on the way, and then I was like, okay, this looks good. And it would be texting you guys, and I was like, okay, like what do you do here?
Even though I had good open skills, good endo skills, I would still lose the revascularization many, many times.
Yes, you can say we're cowboys. You can't say that we're doing this for more RVUs or for like whatever, other than just helping other humans, because all my DVA patients have my personal phone number.
Sure.
There's no other incentive than just helping 40-year-old, 50-year-old people and science.
Welcome back to BackTable, everyone. My name is Sabeen, your host today, and I've got two really awesome special guests. We've got Dr. Lucas Ferreira-Cardona and Dr. Miguel Montero Baker. They can, my accent's not as good as theirs, so they can correct me on that.
Ours. We'll get
I can. But we've got a really awesome episode, and we're really excited to collaborate, as these two also have an awesome podcast, which we'll talk about. But we're going to do a whole series on deep venous arterialization. And there's been a lot of development on all of this in the last several years, especially I think in the last 2 years or so. Lots of new developments. So welcome to the show, guys. Lucas and Miguel. Really, really happy to have you here.
Thank you, man. It's a super pleasure to be here.
Yeah.
We apologize. Our internet sucks here. When we do our batch recordings, we get a Airbnb in the middle of some really cool place, but unfortunately the internet speed tends to be not great. But the beauty about Riverside is it uploads independently. So even though it may be glitchy for us, hopefully for you guys in the audience enjoying our conversation today, it may not be that glitchy. Yeah. So thank you for having us, man. BackTable, to be very honest, is an inspiration for us. And part of the reason why we got Podcast Bandwagon. And so it's awesome to be here. I think cross-pollination is the key to success in everything from CLTI care to podcasting. So it's an honor to be here.
Yeah, it's an honor. I mean, we met that one time up in Ireland. And yeah, I mean, what you guys have built is obviously an inspiration, and it's just an honor to be here with you guys. So thank you. Appreciate it.
Thank you, guys. Now tell us a little bit about your podcast, so all our listeners know. I mean, you guys have really grown. I mean, it's a hard thing to do, and you guys are doing it right. So tell our listeners about your podcast.
Well, the inspiration for the podcast came, Miguel invited me to a dinner in Leipzig at the Link conference. And I think I've told this story a couple of times, but, we were there, and we had played with the idea of a podcast, because I always thought that there was a space outside of the conference room where conversations happen, and those conversations are super valuable. And I didn't see that going on. So we go to this dinner, and all the conversations that I love are just happening at once. It's like one of the best dinners ever. We walk back. It was great. Amazing people. And it's like, I get to do this more. We get to do this more. This gets to be part of our lives. It doesn't get to be once a year, maybe. So that's where the idea came from. Miguel was like, what kind of crazy thing do you want to do? Somehow he's like, yeah, let's do it. And it's been one of the most fun things that I'm personally doing right now. It's motivating. I feel like there's a ton of opportunity every single time I get new ideas, and I'm motivated to do different things with it. But yeah, I'll let Miguel.
Yeah, but my personal story, it's a little different. Is I did academic medicine for many years, and there were some bumps along the way that led me to have to essentially reinvent myself at what I thought was a senior point in my career. And one of the things that I didn't realize I lost is my own voice. I was working for institutions. I was going through institutional web pages. I was being vetted in everything that I wanted to post. It would have to go through, red tape if it was a case, and, all these issues. And what I realized is, man, I have a voice maybe in the conference circle, but I don't have a voice for the people, for my patients, for my colleagues, a place where I can reverberate messages that are intimate and that are mine and that nobody owns. Because that's the thing, is when you're institutionally based, people own you in many ways. And you'll even see, we have to put this thing at the front of our podcast because he works at Del Seaton, and it's, kind of like, hey, this is for entertainment purposes.
Yeah.
Don't judge us on this.
Yeah.
Because it's obviously it's just entertainment. But at the same time, listen, it's become a very powerful tool to get our message across, and people like it, and it's irreverent, and it's transparent, and it's crude. And yes, sometimes maybe you won't agree with us, but that's totally fine, because that's what would happen when we sit down and have drinks. You may be like, dude, I'd never do that.
Yeah.
It's dumb. And then you'd be like, hey, I'd go to this guy. Hey, I'm going to introduce you to this. And so all these networking things that happen was our way of creating that platform. So, and again, inspired by you guys in many ways. We have a little bit lighter take on things than just like a clinical platform. Not to, remove any value from what BackTable is, because we think it's amazing, but it's just a different thing. And so that's where I feel like, they're absolutely collaborative, like, because they're two different things, in my opinion.
And for anyone who's listening, I mean, you guys' podcast is called Life of Flow. You guys have to check it out. I mean, I agree with you. It's a really nice way to have a voice. I really like how you said that, because it kind of brought me to when I joined BackTable around 2018. And at that time, I was like a private practice guy who was trying to go to conferences and talk, and it was just hard, and I wanted to have a voice too. So I like how you said that. Well, how long have you guys been doing your podcast now?
2 years, maybe
2 years, 100+ shows.
Yeah.
And you guys both live in a different area, right? How do you guys always come together to do it?
Yeah.
Is that right?
Yeah.
Yeah. So the way it would work is we had to come up with something that would be efficient. And one of the things that we said is, or this was my ask, because I've got a toddler.
Yeah.
I said, I'm not going to let this carve into my time with my kid. So we're going to have to figure out something that could be fun for him. And what we came up with, which has worked wonderfully well, is we find an Airbnb wherever we want, right? And we rent it out for a weekend. And so I bring my family, my kid, and we find place. This one, we're here in New Braunfels, Texas. There's an entire game room. There's like Mortal Kombat and Pac-Man and pool and croquet and everything.
That's
so
awesome.
My kid and my wife are out there playing. And as soon as we're done with you, the first thing I'm doing is jumping in the pool and getting in with my kid. But then what we do is we then batch. So then we have, back to back to back to back. And so we'll put 8 or 10 shows together. And then we don't see each other for like 3 or 4 months.
Yeah.
And then we do it again. And then that gives us, whatever air or oxygen we need to make sure that they're dropping at a constant cadence.
But I think that was key, because it's not work. It gets to be fun, because at some point when we started, we were going to your office and it felt like work.
Yeah,
it didn't felt like something that we were enjoying.
We weren't disconnecting.
Yeah. So now we come here and I'm excited. I'm like, okay, let's find a really cool Airbnb. We've gone to different cities. We've gone to Leipzig. We've gone to New Orleans. The next one, hopefully, we'll do some place in like the mountains or something like that in Colorado. And then it gets to be fun and into the lightheartedness that feeds into enthusiasm and passion. And I think for anything to succeed, you have to have passion. So how do you cultivate that? Yeah, I'm just saying that we get to make things fun. We get to make things so that they can achieve longevity, and we can always keep improving. If it's work, it's just your heart's not in it. So.
No, and I love it. So you're saying you batch your recordings to get everything done, and then you have a fun ass weekend together. That's awesome. Well, I encourage, everyone to check out Life of Flow. It is definitely, like I said, and something, I know personally with the entire BackTable team that developing a really good, long-standing and consistent podcast is hard, and you guys are doing it. So great job. Yeah. So let's talk DVA. Let's open the table. You guys are experts, all right? And like I said, there's been a lot of development. Tell us a little bit, about both of you. You're both vascular surgeons. We talked about how you are in different areas. I mean, Miguel, you were in academics. Can you kind of just give a little intro of yourself in the setting of just where you are today?
Yeah, so I'm a vascular surgeon, and I'm originally from Costa Rica, but I did training both in Latin America and then Germany. I was with the guys in Leipzig for a few years. I hung my scalpel up for a while and learned from the angiologist, which I think was very incredible. I learned how to fix things that before I would just immediately think the only way to do this is with a knife. But I did it with guys that were internal medicine docs. And so they fixed it in other ways. And it didn't mean it was wrong. It just means it was different. So that changed my perspective. Then I did an American Board of Vascular Surgery here in a group in Arizona, which was very well known for being very progressive when it comes to the complementary multidisciplinary care of the diabetic foot. And that led me to be recruited to Houston now over 10 years ago, where I helped develop the limb preservation program within the Baylor College of Medicine. And it was actually during that time that I realized that I had to find something else, even though I had good open skills and I had good endo skills, and I thought I was decent enough at it, and we had built a really good team at it. I would still lose the revascularization many, many times. And the main reason was these severely calcified pedal vessels, which were not as prevalent, in all honesty, in the Arizona area, but were incredibly prevalent in the Houston area because of the probably higher incidence of end-stage renal disease and hemodialysis-dependent patients that we saw there. And so I just remember my first years being there for hours and hours just trying to cross a lesion, multiple techniques and multiple devices, and then finally get this thread of an artery and come home and be like, man, that was great. All to hear that a week later it was down. So I knew that that was just not the right way. And unless something incredibly disruptive comes, and here we are 10 years later, nothing has come, by the way, because some people say like, oh, it's a matter of technology catching up, then we'll find something to open the artery. Okay, 10 years later, after I recognized that there's nothing, we still don't have anything to magically fix medial artery calcification in, what I call terminal arterial disease. There's just nothing you can do. And I'd been, super, super lucky to have known an Italian crew led by Roberto Ferraresi, Giacomo Clerici, and Andrea Cassini, who had ventured into this venous arterialization world years before me. And when I heard them talk, I said, I got to come. I figured out a way. I carved time, PTO, went to Italy, worked with them for a few weeks. And then my world changed. I said, okay, I finally have something. Now, I don't understand shit about it yet. Like they showed it to me. I don't understand it. And I still today maybe don't understand exactly the biology of it. We've learned a lot more of it. But I know this is a solution because there's a clinical outcome that is evident. And that was it. And so I came back and I started plowing. I worked with the lymph flow folks. I helped to get that device FDA approved. And then the end is history. And I want to say, you want to tell the story of how you came to the arterialization world?
I think, because I think it was the first case you ever did.
Yeah.
Oh, what? Really? No.
Yeah. So I'm from Puerto Rico. I grew up in Puerto Rico, did general surgery in Philly, and then ended up in Houston. And this guy was, one of the attendings. And, being the rebellious person I think I've always been, I kind of gravitated to him because he was like, I don't give a fuck.
Yeah. Exactly.
Yeah. And it was really good. It was really, really
Thanks.
good.
I thought it's because I had good hands.
You did,
Yeah,
but
no, it's just because you're fun.
a little bit of a rebel. And I was like, I like this guy. So we were doing this case, and I've told this story before, but I'll tell it again. A young lady with a significant vasculitis and tissue loss, like 40-year-old.
Severe extreme ischemic pain.
I remember ischemic and tissue loss, yeah. So we're okay. So we're going to do a bypass to the perineal. It seems to be a perineal. We go in, we do a lateral approach, we take out the fibula, we see what we think is the perineal, and then it's just a fibrous cord. It's like there is no lumen in it. And then we're like, oh, what the hell? So we like scrub out, we look at the angiogram again, and we're like, okay, I think there's a PT. Let's go for it. So we go in, we access, cut down to the ankle, and we find a vessel. And we, okay, great. Looks awesome. Let's go in, let's sew it. But we're sewing. Oh, this is pretty cool. Not that bad. And then when we put the Doppler on it, it's just like the lowest resistance signal you've heard in your life. And and this guy goes, fuck.
It's
I'm kind of lost at this point. I'm like, oh shit, I think we just put this to the vein. What the hell do we do?
Yeah.
Did a beautiful
anastomosis.
AV fistula.
AV fistula. Yeah, we just did a beautiful AV fistula.
To the ankle.
To the ankle. So he like throws the gown on the floor.
Yeah.
Grabs his phone, walks outside. And I'm like, okay, so I get to fix this myself? Like, what the hell?
What do I do? Yeah.
20 minutes pass, and he's like, everything's okay. We're going to close. All right, what happened? And then we close, and he's like, oh, I talked to this Italian guy.
That's awesome.
And we're going to do this thing called venous arterialization. Tomorrow, we're going to bring him back, and we're going to go in and light some valves. And I'm like, okay, I guess this is how I get sued. So we go in, we do it. He goes in, he licenses all the valves. Now, in retrospect, I was like, well, that's a badass move because you've never done this before, and it worked out really well. And then the lady, it was a difficult post-op course. At that point, we thought that she had this thing called the venous arterialization storm, which now we know it's all ischemia. But we like, we have to do decompressive TMA and do all this stuff. The thing is, like, the lady did well and healed. And I was like, oh, what the hell did we just do? What is this?
Almost 8 or 9 years.
Yeah.
She's still my patient.
Wow.
And she still has a leg.
Yeah. She's still my patient.
Yeah. So
she's crazy.
Mm-hmm.
Yeah. Crazy amazing?
No, she's crazy.
So then I finish and I go to San Antonio, and Houston was bad, but San Antonio, I think, is like 10 times worse.
Houston on steroids.
It's Houston on steroids. Yeah, because I think like Tex-Mex is like the worst of Tex and the worst of Mex together.
San Antonio is if you order Houston on Wish, you get San Antonio.
Oh, geez.
Sorry, San.
Yeah.
Sorry,
but
me and Charles Barkley have an issue with San Antonio.
I know. But the thing is, like, San Antonio is a 60% Hispanic population. So all my patients speak Spanish, deep connection to my patients.
Yep.
And I was getting 40, 50-year-old patients that had no option. Yeah. Like,
just such bad, severe. Yeah.
Starting families, you're working. I remember I had this lady that was so grateful. She came in and she had one little ulcer in her leg. This is where I just started. So I wasn't doing DVAs. And I think this lady was what prompted me to it. I need to like go back and really take a charge of this. So she came in, she had one little ulcer on a big toe. And she ends up, and I go in, I do all the angios, I do a bypass, I do all this stuff. She ends up with BKA. When she is healing the BKA, she gets an ulcer in the other toe. And ends up with another at 46. I remember
bilateral?
Bilateral BKAs at 46.
Dang.
And I just felt defeated. I just felt like what the hell do I do? Like, there's nothing. I'm not like, I didn't do this to chop people's legs up. That is not why I did this. That is not why I work. So I go to Link, which Miguel told me Link is the best conference. And then I see this crazy Italian guy, Marco Manzi, do a DVA off the shelf with using a balloon to puncture him with an outback, captures the wire in the balloon as a snare, pulls it out. And then I'm like, I'm going to do that shit. So then I get the patient's in like gonna operate. It's like, hey, Dr. Davies, he was my boss. I'm now looking back, amazing guy. He's like, do you want to be the first person do you want to have the first program in San Antonio to have an endovascular DVA? And he's like, what the hell is DVA? And I'm like, oh, don't worry about it. It's super good. So he's like, yeah, go ahead. Just be careful. And I was like, I did it and it worked. And I remember, like, I was looking at the last image and I just like did a mic drop with the control thing. That was like one of the greatest moments of my life. And that's my DVA story. And then after that, it's just been amazing.
Yeah, that's awesome. I mean, yeah, I remember seeing the off the shelf DVA and doing that whole balloon trick. It's just amazing. Like, it's amazing how people come up with techniques to do.
How was your first experience?
Yeah, how's your first experience?
My first experience is, I saw Fatty Saab and Gia do it. People were talking about it on Twitter, and I had this similar patient. She was young 50s and small ulcer, but total no option, just desert foot. And I'm kind of the aggressive PAD guy at my hospital, or my former hospital. I changed. I was like, let's do this. And I had no idea what I was doing, because I was just getting, I was calling like Fatty Saab and some other people. I'd be like, okay, like, what do I do? And similar to like you guys, right? It worked out. On her story though, I didn't understand the whole like large loop. I was trying to keep some short loops open and everything. And that she lost her leg there, but then she developed another ulcer on the other leg. I did a DVA on that side, and she to this day still has that leg. So it was, that was back in 2019, I think, which was fun.
Yeah.
What's cool about this whole venous arterialization thing is it puts in context human ingenuity.
Yeah.
Like, I've never seen it before, right? You said, I figured it out of the need to help, because you had no other, your surgeon wouldn't offer anything. You wouldn't be able to offer anything. And there you are with somebody looking at you for an answer. And it's remarkable to see humans pushing the envelopes, looking at Twitter, looking at YouTube, looking at podcasts, communicating, the WhatsApp chats that we have, like all the thing. It's just this, it just shows.
And it's international.
Everybody saying, I'm seeing the same problem that you are, and we need to find solutions. What works for you? What doesn't work for you? And it's like, it's funny because I'm like, suck it, randomized controlled studies. This is so much better what we've done. It was just like, just went at it from every perspective. We've done it in multiple different ways. And what's happening is we're finally landing on things that make sense. We're finally landing on objective performance goals. We're finally landing. And so it's been a little bit of a cowboyish thing, but along the lines of our personalities, it's been awesome, because it's like, we could be as cavalier if we can, yet being scientifically sound. Don't get me wrong. Everything was done with very clear consent forms, but why not, right? And why not push the envelope on something when your alternative is a death
amputation? Yeah.
And the intention, like that, like these patients require so much of our time. And one of the things that I love is that, yes, we're pushing the envelope. Yes, you can say we're cowboys, but you can't say that we're doing this for more RVUs or for like whatever, other than just helping other humans. Because the time, like, all my DVA patients have my personal phone number.
Sure. Yep.
They all have
Exactly.
my personal phone number, and they send me pics every day. So, there's no monetary incentive. There's no other incentive than just helping 40-year-old, 50-year-old people in the prime of their lives, and science. And like the scientific process in a community, it's been one of the most satisfying things I've ever done.
I agree with you. I mean, and it's the community. I mean, I think the people who are pushing the envelope, like doing DVAs, I mean, like you said, Miguel, I mean, we talk to each other on WhatsApp. We can talk, everyone's very collaborative, helpful. We kind of all are learning from each other. And it's just, you don't see that in other, not fields, but even just specific procedures. I mean, I just think that we have all kind of come together, and we have built this really cool community that I think is just all learning still, right? Well, all right. So you did a surgical. I mean, that's kind of where DVA started, right? Surgical DVAs and anastomosis. You did that kind of on the fly. Do you still do any surgical DVAs, hybrid DVAs?
Mm-hmm.
I still do.
Yeah.
I wouldn't say perfected, but I fine tune the technique, and also gotten to the point where I feel that certain patients are better served with an open hybrid approach than everybody. And it obviously demands some things that aren't present always. But if you have a good saphenous vein, it's a very straightforward procedure, because what you do is you essentially open the below the knee popliteal and you swing the saphenous vein down and you make an anticide anastomosis. And then you puncture the medial marginal vein in the foot. You put a 4-5. And then through that, you put a valvulotome up. And we have surgical valvulotomes for in situ bypasses all the time from Lemater. And then you essentially, you open it up proximally, obviously distal to the anastomosis. You don't want to cut your prolines. And then you just do one pass, and then you take that out, then you suture the collaterals, or what we call perforator veins. And then you flip it to an endo procedure. That's why we call it hybrid, because we just make sure that it's working well, that you have that communication into the LPV. In my observations with those open hybrid approaches is that they actually mature much faster than the deep venous arterialization. And because it's an anticide anastomosis, they don't steal as much as the deep endovascular venous arterializations. And you also have the benefit of not sacrificing anything, because whenever you do a DVA, you're potentially sacrificing, maybe some collaterals distal to the area where you cross the PTFE stent through. And so there's a few reasons why I still think it's a good procedure. When you ask me, out of 10 people, probably one, to be very honest, ends up within the open approach, and most of them, and the majority is because they don't have a good saphenous vein. That's the main reason why.
But I would agree. I recently did one all the way from the common femoral, because there was absolutely nothing, just like stents all the way down, everything, like all the way down to like the ostium of the tibials. And it was beautiful, because I think the other thing is that
But you had a good saphenous.
it had a beautiful saphenous.
Nice.
And it worked amazing. And the other thing,
How's the
I think
patient?
the patient healed.
That's amazing.
Had a TMA, like a really short TMA that had a kind of chronic non-healing.
So like the angio was just a common, and then this long thing all the way down to the foot.
All the way down to the
That's
foot. And
crazy.
at that point, everything, all the venous system was kind of insufficient. So it just immediately lit everything up. But I think the other thing that the greater saphenous vein does is that it modulates flow.
It regulates.
Where
regulates.
You don't really need to do any coiling to take care of any steel. Like if you look at the flow velocities, I've never seen a flow volumes. I've never seen a flow volume greater than 300 with a hybrid approach. So you kind of take that steel, for me, it takes that steel worry out of the picture.
That's nice.
And it's great. The only thing is that in patients that have poor wound healing capacity, old, frail, and stage renal, that I find that I have trouble with the proximal incision quite a bit.
There's
where it breaks down.
Always
Because
surgical site complication.
because these patients really, their body,
Protoplasm sucks.
their body is like suffering.
Yeah.
So is the whole body is compromised. So yeah.
I get it. I mean, so technically the procedure is harder than is it harder, easier?
It's easier.
But the post-op course can be hard because of wound healing and all of that.
The post-op course can be really hard.
Yes.
And you really
In addition to trying to heal the wound of the foot, you potentially have this wound. Yeah. Yes. Okay. So about 1 out of 10. It's awesome. I've always thought, I haven't seen a hybrid approach, in any of my populations, because my vascular surgeons don't do it. How many vascular surgeons out there are comfortable doing, a DVA, a hybrid approach?
HISA, I don't know. But I can tell you it's probably very few.
Out of my group of 8, I'm the only one.
Yeah, very few. I'm the only one. Physician friend, also Eric Peden, just recently jumped in and did one. He was very nice enough to say, I read the article, it was really good, and I really liked the procedure, because I wrote it up. There's a I wrote this up with Jorge and Jill Somerset in one of these Journal of Vascular Surgery techniques or something. So every step by step of how I do it is there, and I still think a lot of people need to just get on the bandwagon. It's just not sexy, it's not appealing, and we don't do it enough for people to jump. But I feel that hopefully, you know, I know like Neville, for example, has been doing a lot. So there's going to be data certainly coming to support the claim that the superficial venous arterializations are also a good option. Yeah. And you know, the other thing is, I'll tell you this, man, is these two systems just, right? I mean, you've seen the DVA. You do a DVA, it goes down, goes into the lateral plantar, then goes out the lateral to the medial marginal vein. We've both had situations where we've actually pivoted. So means, you know, I have one where I did a hybrid superficial venous arterialization, ended up with a very bad surgical site infection, dehiscence, exposure of the graft. I had to ligate it, and I turned it and made it into a DVA, and I still got, you know, limb salvage. Wow. And I think yours was the other way around, where you had a DVA that didn't necessarily do well, and once you exhausted all your options to keep it open, you turned around and did a hybrid, and it worked.
I jumped. Well, it wasn't hybrid. I did it all endo, but made it superficial.
Got it. Yeah, you jumped from
the GSV, from the posterior tibial vein to the GSV.
So knowing that these two systems are complementary, it doesn't matter. I always say it doesn't matter how you get to the kitchen.
Just get down
it's
there.
How, you know, it's getting to the nit grit of the perfusion. So the beauty of having two venous systems that go to the same place offers you 100% more options, right? Because you now have two systems that complementary work.
Yeah, definitely. Yeah. Now, I mean, okay, so still the majority of patients are getting a full endo approach. I mean, these endo approaches were for all off the shelf in the beginning, right? Around, I mean, the description that you made, Lucas, of poking the balloon, or, you know, then came to doing gun sight and all these things. How has the development of the endovascular DVA or even SVA, how has that developed over the last couple of years, in your guys' experience?
Well, in the same way, I think it's one of the really amazing things is picking amazing insights and discoveries from different people and then making it your own. Like the gun sight technique, when I saw like August Isa do the VAS technique, I was like, oh my God. And I now only do that because I find it so easy.
So even if you're doing a lymph flow, you don't use a lymph flow reentry?
No, I do not. It takes me nothing to just put two snares and just do a needle and do it. And then you can play with the angle. After a while, you do something and they're like, actually, they don't need to be on top of each other. They can be a little off. And then I can put the needle at an angle with the transition point. And you kind of like really make the thing your own and like look at every single nuance of it. And you see other people doing it. And I was like, oh, that's like so smart. I'm going to take that. That is something that I feel like we get to do more, which is we get to learn more from each other, the tiny details, nuances that make a procedure perfect. Like the way this guy handles an ultrasound is really amazing. And it's things I wouldn't even think about because he's so fast with the ultrasound and he can apply it in different places. So I think we as a community, we get to learn those things from each other. And we get to find the medium to teach that. But yeah, that's what I would say about it.
I think what we've come to realize is we've created repetition, and repeating the same thing over and over again has made us improve on small things that are leading to a better understanding of what we're doing. We've identified that high volume flows are ischemia producing, right?
Sure.
I know, but like we're like, oh, this is a storm. What the hell are you talking about? There's no storm. You just created a low volume path and you're stealing everything. So we've been better at planning the cases, at thinking, how do we preserve whatever perfusion's already there? We've identified, you know, that coming more distal is probably better. Low flow volume fistulas still mature. It just takes a little more time. We've moved from a stent approach to knowing that there are options for a stent-less approach. And I think here more recently, and I hope that it's taken long enough, so the European Journal of Vascular and Endovascular Surgery has had our paper. Jill and I worked on a really good paper with a few other really good friends about ultrasound.
Yeah, I saw
objective
that.
performance goals, meaning looking at the inside, what's happening with the, when is there perfusion? Because, Jill is great on pedal acceleration time. She's taught us so much, but now it's VPAT, right? Because it's venous pedal acceleration time. And how do VPAT relate to APAT? And anyway, we've learned so much about that I think we're getting to the point where there's consistency in the selection, consistency in the delivery, and frankly, consistency in the outcomes. I mean, I'm not seeing the storms and the severe pain and swelling and stuff that I would see years ago, because we're just much better at it. Like, we've gotten to understand how to do it safely within an hour and a half or less, and get the patient out the table. And quite frankly, now moving it to an outpatient procedure, right? Like, before I would always keep them in house. Now it's like, no, they're coming for an angio. Unfortunately, you could only do it in the hospital, certain types, right? If we're running a study with a Vera, that you could do a DOBL, stentless, but the flow devices codes are tagged to the hospital, like a carotid or a AAA. So those patients still have to come in, but I send them home the same day. I'm not keeping them overnight anymore.
And like you said, I mean, there's been so much repetition, so much more that we know now that we can get these better outcomes. I mean, we're having these objective goals. That was a great paper that you guys published. I mean, I remember going back to my first case, like, I had no idea. Like, I was figuring it out on the way, and then I was like, okay, this looks good, and how much do I follow up? And it would be texting, you guys, and I'm like, okay, like, what do you do here? Do you coil this branch, etc. So it is really nice having these goals. And one part you mentioned was consistency on selection. I wanted to think, do you think DVA is becoming so good that our patient selection is widening and broadening? Now it's not just these like really, really end stage, like that you would go to DVA sooner.
My criteria for the wound has expanded, but my criteria for other aspects of it have narrowed it. Like,
and that makes no sense whatsoever.
Explain yourself,
Thank
Lucas.
you for that.
Family support, family support is
huge.
If you don't have family support, I'm not offering it to you. If you can't come to the clinic, I'm not offering to you, because it's just like, it requires you to text to somebody, take a picture of that wound and send it to me at least once a week. It requires buy-in and commitment. It requires nutrition. It requires the patient to eat significant amount of protein, that to have access to that. It requires a lot, in my experience, in my opinion. So the wound per se, if it's a stable wound, you can probably expand your criteria more than just a little toe. But if it's a frail patient that doesn't heal anything, that has very poor support, then I just don't know that I'm doing that patient a benefit, to be honest. But I don't know. What's your opinion on that?
Yeah, what I would say that I've adopted or changed or modulated throughout the years is, there is not one single current technique or procedure device that, when that device fails, renders the patient in a better place than he was. Okay? Let me go deep into that. With EVAs, what we know thus far is that, let's say, and I'm going to put numbers to just make it as clear as possible, but let's say I meet a patient with a bad wound, no option CLTI, and an ABI of 0.1. Let's say I do a DVA, and this is a successful course, and that DVA's life maybe is 4 to 6 months. In the time where the DVA was open, that ABI is 0.9 to 1. When that DVA goes down, the ABI doesn't go back to 0.1. It stays in the 0.5, 0.6, which, quite frankly, for all of these incredibly frail patients, is more than enough to remain in remission, pain-free, ulcer-free days. And so obviously there is a molecular biological change that we still have to understand better, but there are interleukines, cytokines, and whatever you want to call it, that's creating changes in the way that perfusion is happening. Maybe we're re-recruiting hibernating vessels by jumping through AV fistulae. Maybe there is angiogenesis through the overexpression of VEGF. I don't know exactly what that is, but the reality is you're not dependent on patency. And that, for me, is the magic of this procedure. So what's happened now is that I almost put it at, it's becoming almost like a complementary thing as a backstop. And that could be a little bit tricky because we know that we're in a highly litigious environment where everybody's waiting for you to fuck up to try to come at you for some reason. So you have to be very careful about what you offer, because right now the FDA approved indication is for an absolute no option patient. But like everything in life, you know, TAVRs or EVARs, we threw it at the people that were the worst of the worst, right? And in our cases, Rutherford sixes that we had nothing else to do. And so whatever, you know, like Eric Dipple said, I mean, if the leg's going in the bucket, might as well give it a shot, right? Well, I now feel that it actually probably benefits those people earlier in their condition. You have time to allow for that modulation, and maybe you had a good dorsalis pedis to the foot, you did a good, you know, atherectomy and ballooned it, but you know that patient's going to come back and back and back, and they're going to have restenoses. And so it's almost like, hey, I'm going to do this procedure. You're probably going to get better alone, but I would like to do this procedure, other procedure, that's going to give you a longer term result. Because what I do is open a pipe. It's a mechanical thing. That doesn't change the biology. But this other thing is changing the biology. And that's where I think we have to research a ton more to figure out, why is the biology working? And maybe, right, things along the way as, and I'm not going to steal this from Jill because it was Jill's comment. She said, you know, what about, because I don't know if you guys have heard for the no option where they fractured the tibia.
Oh, yeah, the
TTT, transtibial.
We had the guy.
Yeah, he was on our podcast talking about that.
What is it?
So they fracture. So essentially, for a no option CLTI patient, they just fracture, literally cut the bone of the tibia.
They just cut a piece of cortex,
expand it a little bit, and so then they put, you know, like an external fixator with so you have to do it with orthopedic surgery. Well, the thing is that trauma, that inflammatory trauma, generates so much cytokine and biological attraction that it actually permeates to improving the outflow of the foot. And then for many years, the Europeans have been doing spinal cord stimulators for no option CLTIs and small wounds. We don't have an FDA indication for it, but that also. So is it maybe that all of these, like TTT, like, you know, DVA, like spine cord stims, are there in a way exerting a biological effect that does create a more long-term and sustainable result for these patients? It doesn't negate the need of the acute revascularization via open or endo, but could this be this second thing you do that says, you know, I'm going to push you in the right direction and I'm going to slap you so that you never come back, right? Like I'm pushing you here and I'm slapping you here, and that's going to get you to a place where you don't have to be on my table every 3 to 6 months.
Yeah. One of the things I am dying to try when I know like probably won't work out where I am right now when I open my practice at the beginning of next year is, you know, there's all this. Have you had an experience with peptides?
Peptides?
At all? Yeah, there's different type peptide for different things, and people use it for like trauma and training and stuff like that. So I had this really bad plantar fasciitis, and I was like, it didn't go away. So I started using this peptide called BPC 157. And then I started doing some research, and there's research around it that it does cause neoangiogenesis around it. So when you get plantar fasciitis, it's an ischemic problem of the fascia. So I started injecting it in my calf, and it's improved significantly. So
peptides are awesome.
So I'm like, okay, are there some of these peptides that are causing neoangiogenesis and can be complementary to all these other things that we're doing? Like, there's so much that we get to figure out about the mechanism of action. Cool. Because maybe the mechanism of action can be not tied to a certain procedure, and it can just be like some kind of
Well, some of the observations thus far are leading to believe that this whole thing about having to have an intact arch are also, in a way, being debunked. So,
for the DVA.
yeah. So, like, sometimes the DVA, if you're like close enough to the ankle, even if it's not necessarily progressing how you'd love to see it down the LPV, those patients start getting better in time.
Sometimes.
So could it, like, what is the effect downstream, and why is it happening so far away? And it's not angiographic.
Yeah.
It's not mechanical.
Yeah.
It's not perfusive. It's biologic. There's something there that we still, hot damn, need to figure out.
Yeah. So that's exciting.
True. Yeah.
For all you young, beautiful minds out there, please figure it out.
Like to pipette. I don't like to pipe.
All the smart people out there figure this out. I mean, it's true. Again, just like that, right? Like these things that you've learned now in the last, several years. I mean, how much do you try to go for that arch, that deep venous loop, or do you, if you can't get it, do you leave the short loops, or are you doing more proximal and distal now? Like, what is kind of your most preferred and best outcome patients that you're seeing?
As distal
as possible.
And an arch.
100%. If that means it's mid posterior tibial, so be it. Flow volumes are going to be lower than what you would expect them to, but they still do well. Yeah. Like, even if it's 80 or 70, they still do well. They do well. They just take maybe a little bit longer to progress, but they get there, and you're not creating ischemia. So stay as far below as possible. And I personally try to go as far distal in the LPV when I do my retrograde access, so that I essentially have the valves, those 2 or 3 pesky valves of the lateral plantar crossed, so that I can ultimately come loop back into the superficial system. And that's crucial, the valvulotome. You need to rip the 3 valves down there, or you're not going to have a great loop. Now, I said before that without a loop, some of these patients are doing well, but my experience is the better the loop, the faster the maturation on ultrasound, the faster the conversion, the faster you can get them into the podiatrist to get their foot done. And overall, I think that's what's been helping us. And then very, very, very good close ultrasound surveillance. Like, we see these patients every month.
Yeah.
Every month they get an ultrasound. Every month. It doesn't matter what's happening. Every month until they get remission. Every month I'm seeing these people.
Yeah, I have a couple of things as far as the valves. I would say for the valvulotome, yes, but I'm like more selective with the valvulotome, because like the company would tell you to just like go from the top to the bottom like 5 times, and I don't do that. When you see these veins, they're very friable.
One push.
So I think what I like to do is I like to take the wire out, wait 3 minutes or 5 minutes, and then take a shot to see if any of those valves come back. And the ones that come back, then I treat those specifically with 1 little push or 2 little pushes with 2 valves.
That's gutsy.
And then
that's gutsy.
What?
Losing taking your wire out?
I've been there where you can't cross a valve.
After I obviously I balloon it before.
Oh, it's a valve. It's gonna go fall back in.
Yeah, I haven't had a problem after that.
Well, that's what makes you, Puerto Rico.
That's what makes it me. It's like I make shit work.
Just take my wire off after doing all the hard work. Take the wire off.
Yeah, because I've done the I'm just gonna pass the valvulotome
and bunny this.
And and the valvulotome can cause damage. So
yes. So aggressive. I don't even use the valvulotome for the posterior tibial vein.
No.
There's no sense.
No need. You're gonna cover it with a stent.
You're covering with a stent. So what you need to do is balloon it. If there's any strictures, you use a cutting balloon. 2 places. Then you put your stent. Then you balloon the loop. And then you bring the valvulotome. This is what I do every single time. You bring the valvulotome down through the stent, and you open it right at the edge of the stent, and you pass it 1 push into when the nose turns up. You pull it, you lock it, you pull it out, and that's it.
Yeah, I only do it if I see a valve that needs to be. Yeah,
interesting.
And then the other thing I would say is I try to go into the metatarsal veins and just use a Navi if the angle allows it. If it's not a steep angle, the Navi as a valvulotome into the metatarsal vein. And you can often see, especially if you can get that first metatarsal vein open. I try to do that and that just because Ferraresi said it.
You have to change for an AP view.
You have to change for an AP view.
So you take your Navi cross at the very end, you're flappy, you're going to leave. So just for shits and giggles, keep your Navi in the LPV, go AP, do a shot, do a roadmap, and you'll see it's usually the first little metatarsal valve. You see it there. You'll actually see two or three of these little knuckles. I was going to say nipple, but thanks for that. So you see that, and then you just wire it. And if you could just kind of get it through, then the Navi, you push it back and forth a few times because the valvulotome is too big for that.
Sure,
it's
these are small. These are,
So you just kind of like bump, and then it's going to spaz. You won't see anything. And you just trust the process, like Lucas said.
Trust the process.
And then leave. And usually their time to maturation tends to be,
that's interesting.
As an observation, a little bit faster.
On follow-ups, do you see the metatarsal veins open?
Oh yeah.
Well, you see it post up in the PACU. In the PACU, you hear the signal at the toe.
At the base of the toe.
Wow.
Yeah. And then the other thing that has really improved my outcomes is that I just have a monthly DVA clinic, and all my DVA patients just come see me religiously. At least
There's a lot of wheelchairs.
At least once a month. Yeah. If not, they come off. They come earlier if they're just doing post op. They come every week, every 2 weeks, but everyone else just comes sees me in my DVA clinic, and I think that has helped.
That has helped. Yeah, I mean, the follow up is key. You mentioned as distal as possible. What about any new what are some new devices out there? I mean, obviously LimFlow, you're stenting, Vera. So what is the Vera? What does that do, and how's your experience so far with that type of anastomosis?
So the Avira, it's a very interesting concept. It is a spinoff of the AV fistula device that was made for percutaneous AV fistula creation. And the intention is, can you create a deep venous arterialization by creating an AV fistula without the need to actually put a stent? Because obviously when you're doing a DVA with the LimFlow device, you're using a covered 3.5 to 5.5 by 60 millimeter crossing stent that goes from the posterior tibial artery to the posterior tibial vein. But while doing that, unfortunately, you knock off or knock out the flow to the distal posterior tibial. And that could be very tricky in certain cases, especially those that are single vessel posterior tibial patients. And so with Avira, you have the capacity to maintain antegrade flow through the native system while still creating a fistula that goes down the posterior tibial vein. Now, of course, from a conceptual standpoint, if you think of creating a fistula, obviously the flow would go back to the heart, right? If you create an opening in a vessel and to the vein, then the site of least resistance is going to be up. So with Avira, you have to do two things. You have to lyse the valves, but you also have to put some sort of stop into the vein above the anastomosis. So you would essentially put a vascular plug or put coils, thus blocking the retrograde flow to the right side of the heart and favoring the antegrade flow down the vein through the valves that have been hopefully lysed efficiently. And what we've learned over the years of trying to get this one right is that if you do it very, very proximally, no way. You're going to lose that game because there's too many venous connections between the two posterior veins. So that doesn't work. So you got to go down deep into the distal third of the leg and create a fistula there. The other thing that I think has been advantageous about that, I haven't done it, but I know that some of the guys in the study have done it. This is, not FDA approved, but it is in the phase of approval, is that because of the ease of the system and how you can use it in different areas, a few guys have done a lot of more anterior tibial DVAs. That's something that with the LimFlow device is just not practical because of how small those arteries and veins are. But with this one, you're just creating a hole and you're knocking some veins out here and there, and it actually allows for some, at least in the cases I've seen, for some pretty good flow dynamics in the and the foot vessel arch.
Yeah, I have not used it, but I'm part of the trial.
Have you tried an off the shelf?
No,
because you could do it very easily.
Yeah.
Yeah,
Really?
yeah. You just cross and then put a cutting balloon, and honestly, it doesn't bleed. It does really
In the
well.
anterior tibial?
In whatever.
In whatever.
Whatever you want to do.
People do it
really?
anterior tibial, perineal. That was one of the things I was going to ask you guys. Like, have you done any non-posterior tibial arteries and then
No, I've done perineum.
Whether or not the anastomosis with the Avira device, because it's more controlled and more perfect, is going to probably, I would say probably just logically lead to better outcomes long term of that anastomosis staying open. The reality is, if you don't have anything,
have you done
I've done off the shelf stentless.
Stentless? Yeah.
In the hospital.
In the hospital.
Yeah, and you know what I ended up doing is I ended up doing a coulette with DES stents. So I essentially did the fistula, then I put a coronary, very short coronary, like a 3.0 by like 14.
Okay.
A little tiny,
super short. Yeah.
dude. Yeah, just at the anastomosis.
Okay.
And then when the DVA was perfect and looked great, then I left a wire, an 014 wire there, and then came from the top and put an 014 wire through the struts down the artery.
Okay.
Okay. And then I ballooned the struts so that essentially the D was going into this, and then it had a big hole going down.
Yeah.
So that it's what the cardiologists call a coulette technique, where you can do bifurcational stenting, and they usually put a second stent down.
You didn't.
And I didn't, because all I want is for that to stay open. So I wanted no struts in the movement.
Yeah.
And then whatever struts were open were going into the DVA, and so it's a pair of little. It looks like a little mini pants, like with one leg.
Yeah.
Cool.
What I did is from the venous axis, I put a little vascular plug. Because they're for French.
Yeah.
So you can, from the venous axis, put a little 10 millimeter vascular plug above the anastomosis.
Yeah.
That knocked off the flow, and everything else was going.
What company makes these plugs?
Amplatz plugs?
Yeah. Oh, I look at it. Yeah.
Yeah, I don't know.
Yeah, the MVP I think is Medtronic.
MVP is product.
Yeah.
But these are Amplatz is the one
Amplatz
I use.
is Abbott. Yeah. Yeah.
Abbott. 4 French, Amplatz plug 2. They come all the way down to like 4 millimeters, but for a vein, I'd say a 10 millimeter, easy. Yeah. Put it in there, done. Knock the flow immediately, and beautiful flow down the foot. Cool. By preserving. So what I did is I did it off a perineal.
Okay.
And so
because that's the only thing you had.
Yeah. And so that way I preserved perineal flow.
It preserved the flow.
I preserved perineal flow, and I created the DVA.
Okay. Yeah. Cool.
Yeah. Yeah. No, I mean, there's some upcoming data coming out about some AT and perineal, and it seems, I haven't personally done, I like the posterior tibial lateral plantar vein kind of flow, so I haven't gone and to the different circulations, but the final images I've seen, and preemptively, their results are pretty good. So it's cool. Again, like I said, we're like there's just so much information, so much more like development and broadening of what we can do and save these limbs.
Yeah. What I like about the gun sight technique is that you can go really distally in the perineal and just think that the snares can be far apart, and you just have to, if you line it and with a nice curve, it just looks perfect.
I'm like you. I like the gun sight. I mean, I think that's what do you use, Miguel?
I use gun sight only if I fail with the other one. So it's like 1, 2, 3. I call it 1, 2, 3. So I go 1, 2. If I can't get it, then I gun sight.
Got it.
But I want to say that it's 10% of the time that I have to gun sight it. And it's usually the crazy shit, right? Like weird perineal stuff that doesn't. That's the stuff that I end up doing with gun sight.
Well, one final question: what are bad candidates? I mean, what are bad candidates for DVAs? You mentioned one really good one, Lucas, is lack of family support or compliance. Like that's a crappy candidate. What other things, whether it's from a technical standpoint or anything else that you're saying no, or just like let's keep these options open right now?
I'm moving away from the extreme, horrible, frail patient. Just that, I just don't see if somebody has just significant tissue loss, that before my mind would go straight to that, and I see them and they have an AK, and they're, on the bed, and those patients, just to Lucas's point before, is even if I do a good job, they may not even have biological reserve to heal anything. And so if you try to cut the foot or the TMA, and you try to put that together, I'm moving. I initially only was doing that, and as I said before, I'm moving away from the terminal to ideally finding a sweet spot before they get to that point. Like it doesn't matter. It doesn't mean that I won't do it. Like if somebody comes with a Rutherford 6 and great family and they're all in and they're mentally with it, and I see that their pre-albumin levels look okay, and yeah, I'll still do it. But I am moving away from the ultra frail patient that has a lot of advanced tissue loss, and certainly if there's no family support, absolutely no. But that's the patients that I'm starting to shy away from, man.
Yeah, that's a good. I tried a cirrhotic, I had ascites, and I tried doing one, and it didn't. I mean, again, the protoplasm was terrible.
You got no protein. Yeah. Cirrhosis is a really terrible one to deal with. Yeah. And you just don't have any. There's nothing to sew to, right? There's just nothing to build. There's no protein scaffolding, and it's hard.
Yeah, I think frailty, the capacity for independent living, like if they haven't been having independent living before the ulcer,
sure,
then I just think it's a difficult battle. And then mindset, if they hesitate whatsoever, then it's a no, because it's taxing on their like mental health. It's really taxing. So what you don't want, what I just don't think is worth it, is somebody that gives up just because it takes a long time to heal. Sometimes.
I like that one. Yeah. Even when you tell the patients, hey, this is going to take 6 months, a year.
Yeah.
Then they're in it. Like, this is taking so long.
In it. If somebody's in it, it's like, yeah, I want to save my leg, do everything. It's like, okay, let's go. I'll give you my all. But if they're like, oh, I don't know on this, yes.
Awesome. Well, guys, I know this has been really, really great. I know we could keep going and everything, but you guys got to enjoy your weekend, and we'll have you guys on again. I mean, like I said to all our listeners, you have to check out Miguel and Lucas's podcast, Life of Flow. You guys have done a great job, and it was really a pleasure having you guys on here. And let's do more together. Yeah,
let's do more things together for sure.
Yeah, and if anybody here wants to hear us rant more, we probably did a series.
We
of
have
like
a DVA
5
series, yeah,
where all we did was rant for hours and hours on DVAs. What's worked was not. So if you want to check that out, check it out.
We have one with the whole Italian crew, with Dr. Ferrer,
with Jill Somerset, with the podiatry guys talking about how to reconstruct this. So there's a lot of angles to look at this. So definitely catches there, and you guys let us know anything that we could do to help co-promote and continue to push. So BackTable up. We are here for it, brother. God bless you, and thank you very much for having us.